Okay, ma'am.
All right, so if you've read and understood, considering it critical care scenario, please tell me how are you going to manage this patient now?
According to the scenario, I'll manage the patient according to the ABC protocol.
Yes.
I'll repeat check the airway. If patient is able to talk, airway is pattern. Then I'll check the breathing. I'll check the respiratory rate, rhythm, chest wall movement, and if needed, I'll give the high flow oxygen. Then I'll secure the IV channel, and I'll give the ringer elected solution fluid, and I'll draw the blood for grouping, cross-matching, ABG, and the electrolytes as well as the platelet count and prothrombin time. Then I will manage the patient if needed, and I will consider the component, maybe the Sangsteng black mare tube I can use. And I also use the some pharmacological agents like the vasopressin or octreotide or the IV omeprazole, and the endoscopic treatment also I will consider the patient.
Okay, what would you do next?
If all are failed, then I'll consider the surgical treatment at the portosystemic shunt, that is splenorenal shunt or TIPS, the staple esophageal transection, and in advanced case, I'll consider the orthotopic liver transplant.
What is your differential diagnosis in this scenario?
Yes, ma'am. This may be the case of bleeding from esophageal varices due to the portal hypertension. Maybe the case of uh, Mallory OSTR. Maybe the case of Boerhaave syndrome or bleeding from peptic ulcer disease.
All right, please tell me what is the pathogenesis behind the portal hypertension if in case patient is like considered chronic alcoholic.
Okay, ma'am. Okay, ma'am. The liver cirrhosis resulting from the chronic liver disease characterized by the liver cell damage, fibrosis, and nodular degeneration. And the fibrosis of the portal venous return, uh, fibrosis obstruct the portal venous return and develops the portal hypertension, as well as the arteriovenous shunt in the liver tissue also helps in the development of the portal hypertension.
What if you can mention the sites from where this portosystemic anastomosis takes place?
Yes, ma'am. The lower in the esophagus, where the uh, portal component is the esophageal branch of the left gastric vein, and the systemic components is the azygos vein. In the anal canal, the portal component is the superrectal vein. Systemic component is the middle and inferior vein. In the umbilicus, portal component is the left branch of the ligamentum, vein of the ligamentum teres, and the portal systemic component is the superior inferior epigastric vein. In the bare area of the liver, the portal component is the hepatic or portal vein, and the systemic component is the inferior phrenic vein. And the patent ductus venosus, here the portal component is the left branch of portal vein, and the systemic component is the inferior vena cava. In the retroperitoneal, the portal component is the colonic vein, and the systemic component is the body wall vein.
All right, please tell me, considering the stem, this patient's condition, which one condition can define, or you have to be very careful because of coagulation, coagulation therapy, or because of coagulation crisis that can occur?
Yes, a patient may develop the disseminated intravascular coagulation, patient having the hepatitis C.
Hepatitis C. So there could be thrombocytopenia as well
Yes, ma'am, thrombocytopenia he may develop
because of liver dysfunction.
because of, yes,
Okay. How would you take care of that?
uh,
So, in other words, what are the indications for platelet transfusion
Ma'am.
into a
Yes, I got to mind. If there is ongoing coagulopathy, and the continued bleeding.
Yes.
And the platelet count is less than 50,000.
Yes. Less than 50. All right. Okay. And in case of and if there is prevention of spontaneous bleeding, so it would be threshold would be, then it will be less, like less than 10,000
Yes, yes,
micromole
ma'am. Yes,
and to 30. But in case, and there is another condition as well. If patient is septic or patient is febrile, so the demand
yes,
increases.
yes, ma'am.
Okay, what is one nutritional deficiency which will be present in this particular patient?
Yes, patient may suffering from the vitamin B12 deficiency due to the chronic alcohol taking chronic alcohol.
Okay, because of chronic alcoholism. All right. If you fail to manage this patient, what are the complications that can occur?
Yes, patient may developing the hepatic encephalopathy, hepatorenal syndrome, uh, disseminated intravascular coagulopathy, and acute kidney injury.
Okay, if you could tell me, what are the surgical or invasive management that you can carry out on this patient in order to save him?
Yes, yes, ma'am. I can consider the some endoscopic procedure like endoscopic injection of the sclerogen, endoscopic bending, and some surgical option like the um, uh, tips, that is the portosystemic shunt, and I'll consider the uh, segmental esophageal resection, and in advanced liver disease cases, I'll also consider the orthotopic liver transplant.
Yes. So if you could tell me what are the indications for the usage of Minnesota tube?
Yes, ma'am. If the injection sclerotherapy is failed, if the medical treatment or the pharmacological treatment is failed, and if the center having no the endoscopic procedure system.
Okay. What are the risks and complications when you have to consider using Minnesota
Yes,
tube?
ma'am. Yes, ma'am. There may be the aspiration pneumonia, airway obstruction, the esophageal perforation may occurs.
Okay. And what are the absolute contraindications for the usage of this tube, Minnesota tube?
Okay, ma'am. If there is the recent gastroesophageal surgery, the esophageal stricture
Out here. Okay.
or
Please tell
tear,
me,
esophageal tear.
according to the NICE guidelines, how it should be used or inserted.
Yes, yes, ma'am. At first I'll counseling with the patient about the procedure, and at first I'll duplicate that balloon with the local anesthetic agent and the introduce through the nostril up to the 40 centimeter in the stomach. Then I'll inflate the balloon in the stomach with 500 ml air and back it, and up to the registration get in the diaphragm, and then I will inflate the esophageal balloon with 30 to 40 millimeter mercury and observe the bleeding is arrest or not. If then I'll reduce the pressure 5 millimeter mercury every 3 hours until 25 millimeters of mercury.
Okay.
And patient take the 45-degree
Yes, that is the
position.
most important.
Yes, I
I
have to say
realized
first.
you forgot. The position
Yes,
should be, the
yes,
head position should be
yes.
45-degree angle, and it should be inserted in the posterior pharynx.
Nostril,
Yes.
posterior phalanx or nostril. Yes.
Nostrils of posterior pharynx. Very important. Okay, good. And at the end, you have to deflate esophageal balloon for 5 minutes
Yes.
for 6 hours
5
to
millimeter
prevent.
mercury every 3 hours up to
Yes.
the 25 millimeter mercury.
Yes, this is very important in order to prevent esophageal necrosis.
Yes,
Good.
ma'am.
Thank you.
Thank you, ma'am.